Okay, let's talk about DIC or disseminated intravascular coagulation. So, what DIC is, oh, best I should change the slide. So, what DIC is it's not a disease like where you think that, like, hey, it's its own process, but it's actually its own like disease, like cancer or something like that. It's actually a process that is caused by other disease processes and things like when people are in shock, sepsis, have had a lot of blood transfusions, people that are pregnant, people that have had a lot of extensive tissue damage or cancer are all going to be at high risk for going into DIC. So it's a process that happens. And what the process is an abnormal clotting cascade process. What you start out with is a bunch of clots. So what happens is that you start, pretty much making a bunch of clots because of one of these risk factors like the shock, sepsis, cancer, pregnancy, etc. You make a bunch of clots. And what happens is you make so many clots that you actually run out of all the things you need to make clots. So you start out with a whole lot of clotting, and then you go to a whole lot of bleeding because you ran out of platelets and you ran out of clotting factors, which eventually leads to profuse bleeding. So what does this client look like? They have two manifestations. They have bleeding manifestations and clotting manifestations. So they usually, like, that your patient's in DIC usually because they are bleeding from every orifice. They're bleeding out of their nose, their mouth, their IV site, any sort of open area that they have on their body. Usually there's blood coming out of it. They're oozing blood. It's not like, like an arterial bleed, power bleed, but they're oozing out of every, area of their body that they can. They may have hemoptysis, they may have, throwing up blood, they can have blood in their urine, etc. They also have clotting manifestations, so signs that there's blood clots forming. So they can have, tissue perfusion be altered where they probably have a clots all over in their legs and their arms. They can have signs of a pulmonary embolism like tachypnea and dyspnea. They can also have EKG changes, like signs like they're having a heart attack, or oliguria, like there's clots forming in their kidney um, blood vessels and causing there to be decreased perfusion there as well. So one of the most important things with DIC is knowing what are their labs going to look like. And so, of course, again, everything's about too much clotting and too much bleeding. So first, we're going to look for signs of clotting. They're going to have an increased D dimer, which shows that they have a clot somewhere in their body. And they're also going to have increased fibrin split products, which when you have clots in your body, that's one of the things that shows up. They're also going to have signs of bleeding. So when I check their PT, PTT, INR, APTT, all that stuff, all of them are going to be prolonged. Or in other words, I don't have enough of those clotting factors, so I don't have anything to use to clot. So it's going to take my body a lot longer to clot. And then there's also, again, like I just mentioned, reduced clotting factor. So when I'm looking for all the pieces that make a clot, like platelets, fibrinogen, those are going to be low. So I have increased, all of the things that show me that a clot's present, those are up. All the things that show me that I'm high risk for bleeding, those are up, but everything that shows that I have what I need to form a clot is down. So I know that might seem kind of counterintuitive, but pretty much, again, if you keep in mind what this process is, I have a whole bunch of clots in my body, and now I have nothing to make any more clots. So I have a high numbers risk of bleeding. And then I also have no supplies. Like I've run out of supplies to make clots. So what do we do? Well, we treat the problem again because DIC in itself, I can put band-aids on the problem of too much clotting and too much bleeding. But at the end of the day, if there's something that's causing this process to happen, I need to get to the bottom of that. So trauma, sepsis, burns, organ failure, cancer, whatever it is, I need to treat that problem, give them lots of oxygen and support them. And especially, if they're having, pulmonary embolism, things like that. And then if there's signs of bleeding, of course, I need to replace whatever's missing. So volume replacement, blood, clotting factors, and we give clotting factors through giving FFP and cryo and platelets, replacing again whatever they're low on. If there's signs of clotting, sometimes we'll do anticoagulant therapy. And this might not seem to make sense because you're like, wait a second, I thought this patient was bleeding a whole bunch. And the truth is, yes, they are, but sometimes it depends on the patient. It's not that like they're always simultaneously doing both of these things, but it's really going to be a risk versus benefit situation. And so, there's a lot of patients that I've had that are in DIC that like the doctors has to look at that individual patient and decide like, hey, is the risk of them dying from a blood clot going to be risk of them bigger, or is that bigger than the risk of them dying from bleeding? So what's going to put them at a bigger risk? So that's going to be a case by case basis, and you as the nurse can't decide that. We want to avoid trauma, injury, and any sort of venipuncture. Again, I don't want anything that's going to cause them to bleed because they don't have any supplies to make clots anymore. So I'm going to do whatever I can to support them in that. So as a whole, as the nurse, my job is to assess for bleeding. I'm going to be looking for internal signs of internal and external bleeding. And of course, where do we look? We look for signs, for external bleeding. We're going to be looking, in the nose, it could get dry. The mouth can, and the gums can bleed. They can have GI bleeding in their upper or their lower. I'm going to look in their stool, their urine. And then for internal bleeding, I'm going to check their vital signs. I'm going to look for signs of obvious bleeding, internally, things like that, where there's formation of, hematomas and things like that. And then also be checking and looking at perfusion or signs that they're, losing a lot of blood. I want to minimize tissue damage, any sort of like, I'm going to try to avoid trauma as a whole. I'm also going to assess for clotting. I need to do a good peripheral neurovascular assessment, a neuro, respiratory, and cardiac assessment, looking, is there clots in any of these places? I'm also going to administer blood products and make sure looking for reactions and things like that, and helping to prevent complications of transfusions. And then monitoring their labs and vital signs very closely. I'm very, very much in a role of just supporting this patient who's in DIC. DIC is a very serious disease process that can lead to very serious consequences. It's hard to reverse once that process is started, but people can survive this if we can get to that original cause and treat that problem. So yeah. So hope you enjoyed learning about DIC. See you next time.